Good evening, everybody, and welcome to today's episode of Marvelous Medicine. I'm sorry for the delay in start, and the speaker is Dr.G Sharma, who needs no introduction to Learning General Surgery Group or Marvelous Medicine Group or surgeons in the country. Sir has been like the Dronacharya for the at least 2 to 3 generations of surgeons, and he's a born pedagogue and passionate about teaching, and even more passionate about helping those who are struggling with their passing their exams. So everyone is aware of the regular classes that Dr. Girijadhar Sharma conducts on Zoom for students almost every other day. And he's the last of the breed of the true general surgeon who has operated and can operate on anything from the head to toe, has managed the worst of traumas and most complicated of patients. And today he'll be sharing his knowledge about how to position and brand oneself without depending on somebody else to do the job for you. Moderating the session will be Mr. Rajarajan Satyamurthy. He's currently the Group COO of Ashram Hospitals in Andhra Pradesh, and and the other moderator is Professor Ashok, who is the CEO of Meridian Hospital, Chennai. Over to you, sir.
Good evening, everybody. Today, we are going to discuss a topic which is very close to my heart, and I would discuss the non-conventional methodology, but the old-timer, time-tested methods. Today's topic is direct marketing. In hospital industry, the common marketing concept intermediate person or a team called marketing team who acts as a buffer between procuring business or patients from peripheral doctors, introducing them to their own specialist, and exchange some kind of cash, some favors to the referring doctors. This method is more prevalent, has quicker results, does not require much extra skills to be taught to 150 doctors in a hospital. But this is not a long-lasting method. We are going to talk direct marketing today, and the points we are going to discuss might take some initial hassles to pick up, maybe initially more time consuming, but eventually nobody can snatch your clientele once you master this technique. See, we all want more complex, affluent, and influential patients in more number. The surgical skill is paramount, but some more skills matter in equal percentage until one is a very high-end technocrat who is supported by a team of marketing group. Why do we need marketing? As the number of players is increasing, the cost of investment and the recurrent costs are going up. There is concentration of more skilled people in metros and in bigger towns. So there is more competition. And to break the ice, one has to perform something more than the pure surgical skill. See, there are some basic definitions. Now the law accepts that the patient is a consumer and we are running a medical business. Marketing truly is doing the business from customer's viewpoint. In other words, treating a patient from patient and attender's viewpoint is what is a true marketing. And a good marketing is finding customers, satisfying them with the services and frills, and still make profit. Say there are 20 people, say 20 units in Delhi who are capable of doing Whipple. But to get patients with Whipple, every day, every week, month after month, in huge number, so that you're doing more than 150 a year, it requires all the things. Let me tell you, all people who are successful in life, they are practicing direct marketing skills. After this discussion, I would request you to analyze all those successful people, and they're all doing it. Only thing is they are not sharing it. The direct marketing skills have surgical skills, cost of the total management, availability of the clinician, team, hospitality, and cash sharing within the team. We'll discuss one by one. In any team, on an average, a senior consultant spends 3 to maximum 5 minutes with a patient once a day if the patient is lucky. The JC spends 5 to 10 minutes twice a day. The resident spends an hour to 2 with the patient. And the nurses spend the most time. So the satisfaction of a patient depends on role of all these people. A good team leader is who keeps that team along with. Remember, a good skilled person is one who appreciates in public and criticizes in private. It's a great morale boosting to the team. When on rounds, I'd say, Dr. Lokesh is probably the best surgeon I have known for his age. And one day I'm sure he will be more skilled and popular than what I am. You can imagine how much ego of my junior consultant will be inflated. If I tell a sick patient getting well that Mr. Mohan, Sister Susie has done so much for you and your quick recovery, I will attribute a lot to Susie. Now, it is not only you are appreciating Susie, it is 3 more nurses or 2 more technicians who realize the team spirit that today is a Susie, tomorrow it can be Anne, and day after it can be Shushmita. So carry the team along with. When you appreciate these people, there are several long-term effects. Remember, a patient is waiting. The attenders are waiting since last night to hear 2 minutes or 3 minutes senior consultant, what he is going to say. So these words get embedded in their memory and mind. When I say my consultant is very good, it doesn't lower my esteem. It actually raises the respectability of the unit. When I say it repetitively, they believe my junior consultant or associate consultant. They do not trouble me in middle of night. I sleep well. This guy is happy working. Patients are happy. They respect the decisions of my JC or associate. They say, oh, Dr. Sharma said he's very good. So whatever he's saying, so that creates an aura around the team, the nurses, the technicians, and their effectivity increases. And the total respect of the unit increases in public's mind. We cannot say, oh, I'm good, JC is bad, associate is bad, the nurses are useless. Then probably I am also useless as far as public is concerned. To keep people motivated, remember, small gifts carry a lot of meaning. I always find an occasion to host a party for the unit. Any sick patient gets well, we host a samosa or a donut party for the nurses and technicians and appreciate how nicely they managed, how good they were in giving physiotherapy, how the timely pain management helps the patient to recover. And I always say with a big smile, thank you, sister. Now a samosa party for the nurses or donuts. And at times we hand over some small gift for them to keep home, carry home, some donuts for their kids. A resident who has worked well, so see, the gift has a more value which has relevance to that particular person. If I hand over 2 tickets for the latest Amir Khan movie to my resident with food coupons, one for him, one for his girlfriend, he not only feels pleased, he feels that there is somebody who is concerned about me. If I hand over a nice toy of Hamlet for my JC's son, that has more impact than giving him 5,000 rupees. Remember, tailor your gifts, tailor the timing. Somebody has done good job giving a gift there and then. I normally have a variety of gifts packed and lying in my car. I only have to tell the driver, please get this from the car. I may use them twice a week, thrice a month, or may not give a gift for a month altogether. If I have to give a gift to my boss, I will try to find out what he likes. Remember the famous quote when Dale Carnegie wanted to catch a fish, he hung some chocolate cookies because Dale Carnegie liked chocolate cookies, but couldn't catch any fish because the fish likes earthworm. So hang an earthworm. So frequent, small, appropriate gifts make a lot of difference in the team members. The next important person which we interact is a referring doctor. We first need to know the potentials of a referring doctor and the trends of referring from a given town. Now there are set patterns in which the patients have traveled in last 2-3 decades. Interestingly, people from Calcutta come to Chennai for treatment across India. But that has been the trend for decades. Now, if you want to bring people from Chennai to Bombay, it will not happen. Similarly, there are districts in NCR which go to Rohtak Medical College, and there are districts who come to Delhi always. So we should concentrate into the geographical pattern of referral. Current trends. Now, if there is a clinician A who refers all his cases of surgery to a surgeon B, try to find out why. Is B very good? Is B economical? Or B is his classmate? Or B is his brother-in-law? If it happens to be his brother-in-law or a classmate, don't try to bang your head against a wall. Don't even try. I will exclude that man right in the beginning when I know what is the pattern. And if it is first two categories, we will try on him. Now, I would categorize my referring doctors as A plus, who has lot of business and give us lot of business. Category A, who have lot of business but oblige us now and then. Category B plus is the gentleman has moderate business, shares with us frequently. And B is those who have moderate business but helps us sparingly. So our effort should be in converting, number one, retaining A plus candidates, converting more A's into A pluses, more B's into B plus. And C, we don't need to waste our energies, as this is the category which themselves they don't have work. What are they going to help us? Then there are concerns of the referring doctor. Now, somehow in life, I have enjoyed both aspects of this issue. I am a referring doctor for few, and I am a receiving doctor for several. So the commonest thing is casualty encounter. When somebody following a lap cholecystectomy has developed biliary peritonitis or a fistula is referred to a friend in the higher institution, the first thing that DNBGI would say, oh, अब मरने वाला हो गया तो यहाँ ले आयो. That spoil the whole show. When that happens, one loose talk by a junior will disconnect your link forever. So we need to educate our juniors how and what should they say in any given specialty. Like in urology, you are going to get urethral injuries, strictures from periphery, renal trauma, urinary leak. So there should be set dialogues. There should be frequently asked questions and set answers which our residents are going to give. Then the next encounter is with assessment office. The assessment officer in all corporate hospitals, we are willing to do at the rock bottom prices for CGHS, DGHS cases. But when you get a cash patient, you squeeze the patient. And the assessment office demands abnormal amount of money at the time of admission. The next important point is AM rounds. When it is 10 a.m. and the family is waiting overnight, they are always concerned. They ring up their primary physician or referring surgeon that we are waiting overnight. No senior has come and briefed us regarding the patient. The counseling should always be done in a room. And while handling the complications, suppose the common issues which dissatisfy a family and the patient is somebody who was operated for an elective case in the middle of night is shifted back to ICU. somebody who needs re-exploration, somebody who has abnormally bled, or somebody who has become septic. No, these are the situations, or somebody has got a cardiovascular event. Before you break the bad news to the family, please talk to the referring doctor, because as soon as you are going to finish, they are going to ring up the primary care that where have you sent us? Our patient is not doing well. So he should have the exact situation even at 2 a.m. The business growth and retention depends only on two things. I would put the second point first. Repeat customers. Are people happy who are getting out of your trolley area? And are your referring doctors happy with you? Have they got more confidence? Who will be, dear friends, a happy patient? When he goes home, he says, such a nice surgeon he was. He was always smiling. I did not have any pain after the surgery. He was there whenever we wanted. We could talk to him and he was pleasant each time. The team was very good. His number two, Rajkumar, was very good. And then they say the nurses were willing to go a mile extra. The dietitian looked after us. And you know the final thing they would say? The final thing is the bill was well within the estimate. Dear friends, repeat customers never happen. Number one, when there is a major complication. Number two, when somebody down the lane in the tube, in the team, misbehaved or was not available. And number three, when the cost which was explained and the cost which was finally billed is tremendously apart. Let me tell you, most surgeons, this is a large survey to prove, the most surgeons in their OPD, that they give a quotation 30 to 40% less than the actual subconscious mind because they don't want to lose the patient. I have lived with a concept. I always, in my unit, we always give a quotation 10 to 15% higher than what is expected, so that we can tell in the end of the day, well, your bill was going to be 55,000 rupees, but somehow we have tried to economize and it is only 51,000 rupees. Anybody, even the richest of rich in India, wants some concession. And this is the one way for retention. If you may not give concession, max to max, your bill should be not more than 10% higher than what you quoted. Let me share with you philosophy of Christian hospitals. I'm brought up in a Christian hospital. One of their successful USP is they have a very senior paramedic as an assessment officer. There's a place where somebody goes, sits across the table, a peon offers a glass of water or a cup of tea, and then that fellow will say, sir, the gallbladder operation for your wife will cost 100 rupees. Then he will look at the facial appearances of the gentleman. He says, anything else? He said, your wife is going to have one-time operation. You can please her by getting into a private room. You are anyway for 2 days and it will cost only 20% more or 40% more. And you can read, then in one breath, he will say, you can read your newspaper, you can put your lights the way you want. You will be the only person using that restroom and so on. So, like we go to a Raymond shop to buy a pant or a shirt, A smart salesman sells the suit also. So is the hospital assessment officer, who at one time can sell the suit. At the second time, if there is somebody, if he says, how much will it cost? The gentleman says, oh, this will cost you 40,000 rupees. Then when he looks at it and the man is trying to get up, he says, what happened? He says, you are too expensive. Now here the role of a smart person comes. When he says you are too expensive, he should not be saying, oh, no, 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 we are very cheap. See, if your patient is perceiving you are too expensive, you are too expensive. You should utilize Aikido formula, which is always agree with your opponent. And then he would say, I agree, the cost is your concern, but I want to help you. Let me talk to my medical director or trustee. Maybe I can get you some concession. I can't do anything, but my trustees are here today. Let me put up your genuine case. You have a cup of tea, I will come. He goes from one side, goes to the washroom, comes back, offers 5,000 rupees less, gets the guy admitted. These are the ways. In the hospital industry, the competition is rising. We have already said so. Surrounding hospital competition, we cannot do anything. But we need to be vigilant. What new equipment they are getting, what new consultant they are hiring, what new technology are they bringing, and then analyze, can we bring them? Can we upgrade ourselves to match them? If feasible, we should. If not feasible, we should not. If I am running a small hospital, I should not get a loan of 15 crore rupees to start a robotic surgery when I don't have business for robotic. But whatever I can, I should. The competition within the hospital can be to large extent abolished by referrals and counter referrals, so that I say, oh, Bose is the best joint replacement surgeon in our unit. There's nobody like him in Asia. And he says Smith is the best urologist in our unit. As far as I know, there's nobody in north of the country who matches that. Then the competition within the unit should be zero. Everybody should have financial interest in other man's earning. The complex case which boss is doing, the JC must get some money out of it. And whatever JC is going, the proportion can be different. It is what I'm trying to say, every patient is everybody's patient. A common saying in the coffee room of most private hospitals, when I have heard, and I'm sure you guys have also heard, people saying, oh, I hate doing these CGHS cases. I hate doing this Bodhi panel, and I hate DGHS is just waste of energies. Now remember, 50 crore rupees are, 50 crore population is covered under the government health scheme, Ayushman Bharat. So your every third patient has to be Ayushman. Now you have to find out the modalities. How can you work economically and make profit out of it? The cash and TPA in most, I don't know about the data of South, but in North, all hospitals have got 80%, 70% business coming from these government panels, which are low paying, and 10 to 15% TPA and 10 to 15% cash patients. Now, one important thing I want to tell you, that this couple, which is a retired MCD couple, number one, they are also humans. They need to be taken care. Who will operate them should depend upon the sickness, not their financial category. And remember, and I'm witness to this through my journey of life, that every poor patient, whole family is not poor. I have done CGHS patients. The father was a peon or a baildar in MCD, and the son was a computer engineer in Infosys. When we did the mother well, the daughter-in-law came in with a 10 lakh insurance policy to the same doctor. I must share with you an interesting story. In my town where I practiced around 38 years, one maid I operated who was very happy with us for our services, and she was working in one of the richest lala of my town. And every day she will go and sweep the floor. She would sing my song. And so it so happened that after some time, the wife of that Lalaji also developed the gallstones. My unit was meant only for a common man. I have run a very sort of economical unit where everybody could get a neat and clean surgery with no frills and reasonable charges. Though those people were going for their sneezing and nasal allergy to get Allegra tablet always from Gangaram Hospital, but that maid convinced that rich lady that she was operated in my unit. And then a chain reaction started. Remember, there's a pattern. We need to have patience. We need to learn from a farmer. A farmer continues to look after this calf for 1 year, 2 years, 3 years, never looks at the calf and say, 2 years, no milk yielded, 3 years, no milk yielded. He knows the first drop of milk will come at 3.5 years. Similarly, friends, the patience. The pattern is first poor people will come to you for their hernia hydrocele surgery. Then the middle class people will come for gallbladder thyroid. Then rich people will come for circumcision. Then rich people will come for complex surgical procedures. This is the pattern. Patients like this will also come to you if you keep doing your work with sincerity and consistently. Training is what matters. In 3 years, we make a general surgeon into a cardiac surgeon. We make a MD medicine into an endoscopic gastroenterologist. But the success of that person will 50% depend upon how technically good or academically strong that person is. The rest 50%, his conduct, his attire, how he speaks, what is his body language, how he communicates, depends upon his direct skills of communication with the patient. And somehow I find in last 4 decades, this part of training is strongly lacking. I meet boys from some of the best places in the country, like PGI Chandigarh, like All India, like SGPGI, and I find they are technically excellent, but how they communicate with the patient, they get near zero score. Somewhere in the line, the elder generation is failing to educate them. So teaching these skills is equally important as teaching them surgery or medicine. A hint for the administrative people in this group: remember, your best pieces will be picked up early. If Max neurosurgeon is picked up by Medicity, then Max will pick up a neurosurgeon from neighboring hospitals. So we should be alert and keep our number one people happy. At the same time, we should keep our number two happy. Why? Because the whole team should not migrate in one piece. The unit will collapse, the services will go down. So we need to pamper our number one and number two separately, which most of the administrators are doing. Is just a small reminder. This gentleman did a CTVS from All India Institute and pediatric cardiac surgery from Cleveland Clinic. He has been trained in the best centers in India and abroad. But my question is this evening, for your grandchild surgery, will you prefer him or prefer a gentleman like this? Obviously, the later. Harvard University proved that 7 out of 10 people, if they have met a surgeon who is formally dressed, pleasant to talk, has good communication skills, will get operated from that surgeon even without looking at his Google data, what his complication rate is. And this is what I'm trying to say. This part we can educate our youngsters. And this is an important thing to score high in business. Always have a open door policy. Remember, listening is the best form of communication. For sick patients, for patients who are going to be unsatisfied. Who are those? I repeat, those who have unexpected complication, those who have bled and gone back to theater, who have developed a medical complication going to ICU or medical ICU, which was not expected out of them, those whose bill is increasing, those who have been on ventilation for long. When they come to talk to you, give them time, ample time. And it has happened frequently. If you sit down and draw with a line, diagram, and explain them that these are the that these are the modifiable factors, what we are trying to help the patient. We cannot change his age, end stage renal failure, his diabetes mellitus of long standing, his 2 stents in the coronary. So if we explain everything, then a common error happens is first his 2 sons have talked to you and taken away your 10 minutes. By the time you were going for your coffee, now his son-in-law and the third son has come. He says, sir, we got late. Can we ask something? With a smile, you should say, yes, please come in. I am here all for you. Now, these few words exhibit your sense of concern and also add to the patient satisfaction. Always talk to an unsatisfied patient in private in your office. Always get them saying, yes, yes. Now, if you want to convert an arrogant person into a docile person, always ask certain set of questions. I appreciate how much you are concerned about your father. What is going to be the answer? Yes. Though they have brought their diabetic gangrenous foot father 14 days, when the toe gangrene has spread to the leg, I still would say, I understand you are so caring, son, that you brought him in no time to the hospital. Remember, if you compare this with another doctor who says, you never bothered for him for 14 days, from the toe it has gone to the ankle and knee, and now you are trying to blame the hospital. Now, who is going to have more fights? So, we have to be diplomatically smart to convince. And next point is we should chew a bite as much as what we can chew. We should not take up cases which are beyond the scope. The fact that as an assistant professor in All India Institute, I used to do such cases regularly, does not mean you can do all those cases in a remote area where the infrastructure paraphernalia is poor. And such a crowd outside the OPD in a fighting mood, nobody wants to appreciate. This is one condition which none of us wants to happen. When you are anticipating trouble, please call your other friends and do the counseling in a joint way. Always involve your surgical uncles to help you and bail out and shoulder the responsibility when you're in trouble. When there are more security and police outside the casualty, this is the perk only with 2% of surgeons in India. 98% have to face their music themselves. All they would have is one security chap who also may run away when the mob turns violent. Now, we need to learn from this gentleman. This guy is shearing wool out of a sheep. Now he is smart. He's taking only wool out. He's not taking the skin out. So this is a famous Haryanvi saying, which people, the villagers say to the doctor, please remove only the hair, leave the skin behind. What they're trying to say, charge as much as you can charge us again. Let this not be the last charging bill of yours so that we don't come to your hospital. The common saying which happens in North must be happening. This lady had umbilical hernia reported on CT scan, and since the billing for umbilical hernia is low, so the surgeon tried to bill the patient with the incisional hernia, umbilical hernia, epigastric hernia, subxiphoid, and forwarded the 4 codes. Commonly happens in anorectum when there are every patient's billed with hemorrhoids and fissure and maybe submucous fistula. 2 years later, when you look at the discharge card, you can't make which one out of the 3 this patient had, because we have gone that low to overbill. And what happens? Sometimes the whole bill gets cancelled because there is no documentary evidence of all other things. Dear friends, today the poorest of poor also does not have time. So when you give the public time 9, it should make to you 8:59. Nobody wants to wait in lines. No. Second point, when people are waiting outside, you should not be served tea and pakoras in your office. You can go out for coffee, which you should, but your nurse tells the doctor has gone to see a patient in ICU. Doctors are not supposed to relax. They are not supposed to take coffee. They are not supposed to have lunch break. Every time we are not available, we are seeing some busy patient, but some serious patient. But then you need to have smart staff who would act like that. Friends, consistency is the key. When I say consistency, means consistency of skill, concern, attitude to help, and transparency, availability, and punctuality. Until you don't do it regularly, and if you do it regularly, by 5 years you get recognized, by 10 years you get the public warmth, and then later on it is all your bonus. Now, in most hospitals, we see a scene like this. There are two units of surgery, unit A and B. They are trying to pull each other's leg, and both are getting unpopular. Instead of this, four people working in one direction will take the department much more forward. So we should create some kind of environment where we are working all for the progress of each other. There's a common saying in Sikhism, Sarbat da Pala, let God help everybody. In that, I am also included. Now, we all youngsters who are influenced by their role models want to be well off. They all want a sea facing bungalow if they are in private practice. And my friends who are in teaching, they also have a reason. They want to do more and more number of cases, complex cases, polish their skills, learn new skills abroad, and practice at home so that later they encash. And they want to have more scientific publications. For all this, even a government hospital, one has to be result oriented. Some of the best people who are multimillionaires in daily private practice, they struggled 25 years in government hospitals. They went to Karnal, Kurukshetra, Amritsar, Hoshiarpur whenever there was a CME. Probably their kids never saw their face on weekend because they were educating and spreading the gospel of surgery far off. They were courteous in government sector. Even people said, well, one gentleman, a couple of them I can vouch, they said, though the toilets were filthy, but the doctor was so nice, we kept hanky for 3 minutes to have 23 hours and 57 minutes comfort. So a courteous, skilled, smiling doctor, even with some stained bedsheet, people preferred. And friends, growing in growing competition, the crowd must know that you know your specialty, you care for them, you are available when needed at the cost which they think is reasonable. And finally, customer is the king. These are few time-tested methodologies which cost nothing. One important thing we somehow skipped is the dietary department, which also keeps a lot of goodwill in patients who are going downhill. Serving a tasty food of his choice pleases one and all. So, dear friends, here I close. I think uh, we can get back to discussions. Welcome, sir.
Doctor, wonderful presentation, very good. It was a nice coverage of the entire gamut of hospital. You have nicely covered everything, the patient coming in, how they are getting treated, and who cares them, and finally, what impressions they leave when they go. I think you have covered operations, you have covered patient care, and also you've given some tips for marketing. It's really good. what I'm quite impressed about your presentation is that, doctor, one particular word called motivation. That's really great. That is internal marketing. And employee engagement is a order of the day in corporates. But in all promoter-driven organizations, still it's only hire and fire. And I always say in the hospital only two fundas are there. One is called A square, accuse and attack. The second one is called M square, motivate and maintain. Everybody wants quick results. Everyone wants quick conversions. So that is absolutely, that is fantastic. That giving small gifts, motivating them, and not shouting at them. It's really good. That we call as internal marketing. At the end of the day, we have to sell ourselves to everybody, whether it is a patient or a colleague or other thing. That's really good. But there are two categories which I would like to say is that, like we always say, there are two aspects. One is sales, the other one is marketing. And sales is the direct sale, which is a number game, we say. And marketing is the one which covers everything. You got digital marketing and you got media marketing. So it's a big subject. And as far as clinics are concerned, everything is required today. As you rightly said, without marketing, nothing can be done. But I'm very happy that the word of they call aversion. When we talk about marketing, nobody likes. But today, without marketing, nothing is done. Because as you covered referral marketing, we say 15 to 20% of the business is driven by referral marketing. It may go up to 50% in some areas, and the other segments, it's quintessential that we should have a different techniques. And I always say that you can have machines, you can have doctors, you can have buildings. Who will bring patients? Patients are going to come only through sales and marketing. As a direct student of Philip Kotler, I am wedded with the concept that the marketing can move mountains. And the days have gone that, the good work people see and they come. No, there are good surgeons, they don't get patients. And there are good doctors, they don't get patients. But there are ways how to bring patients, how to bring footfalls. So I always say that two P's in the hospital. One is called prescription, the other one is called perception. And you can promote only either the procedure or personal. Only these two things can be promoted or marketed. Anyway, good presentation, doctor. And I think it will be very useful for them. And it's very nice that you talked about something like DAC marketing or internal marketing, the human skills. Anyway, good presentation. Thank you very much.
Thank you.
Over to you, Mr. Rajarajan.
Yeah, good evening, one and all. Thanks for having me here. It was a wonderful presentation, well thought out, and very appealing to the section of doctors. The way Dr. Girija had put it together, Sharma sir, it was really good. Some of the aspects which were covered is very organic in nature. If these things are focused upon, the fundamentals of marketing these way. If these things are focused on, further things can be built upon. And as Professor Dr. Ashok Tyagarajan sir had mentioned, you can move mountains. It's always the intent. And one other aspect which I had definitely liked about the presentation is to have the kind of patience and to toil, running around to Hoshiarpur and Karnal, especially in the NCR region, and similarly for all the outreach clinics and the various CMEs which our doctors from various parts, various cities travel uh, as something which spells their success over time. And some of the things which in this new age, I just wanted to add upon, which doctors need to really look at. And thing is the online reviews and testimonials. Today we live in a digital world, and somebody who's not in Google My Business, you might have a clinic address, you might have a hospital address, but if you don't have a Google My Business configuration done for your name or your hospital or your clinic, you are not going to be very successful in the new age. So it is now started becoming some of the hygiene factors. uh, Another important thing is, which is again forgotten in the new age of marketing, is about the transparency in communication, well brought out by you, sir. And one thing, as even a quality aficionado, we keep talking about the frames and prompts, patient reported experience measures and patient reported outcome measures. So having a very good scorecard for these, say for patient-reported experience measures, various hospitals employ net promoter score methodology. For patient-reported outcome measures for different specialities and for different procedures, there are very many international publications which does talk about the scorecards. And these scorecards are also something which are going to project the kind of success that you have for the young doctors. So focusing on the patient-reported outcome measures, and in fact, one of the earliest hospitals to successfully come out and put the clinical outcomes was Fortis Healthcare Group, which had put it earlier in India, but earlier it was Cleveland Clinic, which had put it internationally at first. So measuring and managing your success with international metrics is always going to help you grow in this growing competition. Thank you very much for having me over here and look forward to further interactions. Thank you.
So the meeting is open for discussion. If anyone has any comments or questions, please feel free to use the electronic hand raise, or just put your hand up. Put your camera on, and we'll come to you. So yeah. So before as people are getting ready with their questions, Dr. Punidhar, you want to add something?
Not really. I think very well covered by Dr. Girja. As one of the commentators said, that it's really true that we are changing. It's not necessary that only the good doctors will get the patients. I think that subtle marketing is important, and each one, as Dr. Girja pointed out, each one is an agent for the next one. I'm seeing that live as we started in Amrita here in Faridabad. After first year, we had very few patients because there were no, all these agencies and recognitions and all those things are not there. But the second year, when we, more than all those what do you call them, panels and all that, much more than that was when a patient says that, so-and-so patient told us you have to go only here, you'll get the right advice. So I think that internal marketing, external marketing is extremely important. And as Akhila just said, that the soft skills will go a really, really long way. I personally feel if you're genuine and not worried about the marketing thing, it automatically acts as a subtle marketing tool because, I think there was one patient who came to me, had visited all the top oncology centers in Delhi and said, doctor, now we are confused. We don't know what to do. We've gone to all these number one, number two, number three centers. They're all good centers. What do you think we should do? So I told them that, I think you should go where you feel comfortable. Don't look at the ratings of the hospital. Look where you're comfortable. They went back, and next day they called up and fixed an appointment for the third day for the surgery. So I think if we can convince them without actually marketing or peddling, and we are genuine, I think the direct sales that Dr. Girja is talking about automatically comes through. Thank you. I think it's a very, very important topic. The youngsters really need to know, because there's a bravado that, now I have that degrees added to me, and I'm going to automatically get those patients. The hospital better pay me. I think very, very important and timely topic, Dr. Vidya.
Thanks, Puneet. Dr. GDS sir, there are some comments about how you should, follow up with the referring doctor. So would you like to highlight, sir, the communication? And you did say that when the patient turns for the worse, you should inform and all that. But can you go from the beginning, even if it's a simple referral, like somebody, I know you're a surgeon, but since the audience is mixed, So even if it's a referral for a medical problem or a minor surgical problem, how do you communicate with the primary consultant who has referred to you? It may be a general practitioner who is referring to a specialist of medical or surgical.
Yeah, I would start this with a bit tougher word, that even our dog doesn't like criticism. So when we are talking to people who are in a small place, less equipped, first thing is I would always start with the appreciation that Dr. X, whatever you did as an initial treatment was very good. Nobody minds that word. Everybody appreciates. Then we inform all of them on arrival that your patient has come. And this is our plan. Then after the treatment, we inform them. Since we do not give cash benefits to our referring doctors, so I have developed a modality where I will, when the patient is 80% okay, I will write down the treatment and send the patient to the primary care referring doctor. That you now, and I will make the patient convinced that if you stay here, the bill is 50,000 rupees per day. You go back to your primary doctor, and we will have a video chat regarding your progress every day. And now in that process, if that doctor keeps the patient for 2, 3, 4 days, whatever was the residual treatment, he makes his 20, 30, 40,000 rupees. So I have given him nothing. He has got some financial benefit, and the patient goes back to him, and the patient goes home from his clinic, not from my hospital.
Thank you, sir. Dr. Venkatesh, you had some comments on the chat box. Would you like to elaborate on that?
Yes, ma'am. Sir, excellent talk as usual. Brilliantly outlined the necessary things that are needed for a practice. But this is something different, not just pertaining to marketing by the doctors. Most of the marketing is done by a different set of people. So when we, as somebody rightly pointed out, when we say marketing, it sounds very bad. I mean, so marketing is necessarily has got a very negative connotation in the minds of most people. But when we say marketing, what are the truly downsides of marketing?
Downside is that most people come to know that how much money is being exchanged.
I
Yes, that happens in all diagnostic centers.
Yeah.
Everybody in the public down the lane knows that whatever the doctor is referring to a given city center. So somehow public is still not clear that if I say you go to diagnostic center A, right, he will go to always center B. The poor man does not understand whether he goes to A or B. The envelope full of Mahatma Gandhi will come back from either of them, right? So number one, I always tell, I have two kinds of patients. One, who are my old patients, or they have come through one of my old patients. There I give a honest opinion that, look, Dr. Abhishek Jha is the best sonologist and radiologist in our town. Go to him. Then there are mobile patients. When I say mobile patient means who have just come shopping. So I will write 3 names. You can get it done from either of them. So that keeps me relatively cleaner. Then I have propagated a concept, I'm just repeating, of a surgical uncle. Surgical uncle is a person who will help you without a reason, motive, or purpose to bail you out. So we need to have a surgical uncle in each specialty. And one has to be known to or friendly with some of the top people. If I have to refer a patient, I will say, look, the patient, suppose I have done a TURP and the patient has developed stricture urethra. So I will tell him that you should take a second opinion, but they say we want to go to Delhi and show to Dr. XYZ. Then I will tell him, if you are going to Delhi anyway, go to the last man first. He will say, what do you mean? I say, go to Professor so-and-so. He spent 25 years in All India Institute, where you could not see him in less than 6 months of your repeated visits. Now just give 2,500 rupees and he will be available. And I can help you in fixing the appointment. That looks very soothing to the public, that he is referring us to the senior most person. I'll advise all my friends that looking into the pattern of referral, if you have to refer to the top people. Top people may not give you money, but they will bail you out of your problem once in a while. I have a GI friend. I have several GI friends. So one day I sent him a Fisher in Nano. So he called me back in the evening. He says, GD, you sent a Fisher in Nano. I said, what can I do? For last 2 months, I couldn't get a CA esophagus or pancreas, but then I have to keep the account open. So I sent a Fisher, right? So keep the account open with your more popular and more skilled friends and refer to them only.
Sir, the perception of the public when they come to the hospital, the doctor being the face of the hospital, most of them think that any kind of cost, any kind of overheads, any kind of financial transaction that happens in the hospital, the doctor is directly connected to him. And especially when the doctors are working for a salaried doctor, and the first question the patient is going to ask, how much it's going to cost me. Do you think it is advisable for doctors to engage them in this kind of conversation, or would you like to suggest something alternative?
Absolutely not. As I told you, that number one, I discussed the assessment officer's role. The doctors are poor communicators on finance. Most surgeons, they quote 30 to 40% less than the actual bill by their habit. So I gave the example of Christian hospitals where a smart communicator is the assessment officer who can sell a room of higher category to a given patient when he finds he is wealthy, and he can give concession of 5,000-7,000 rupees himself in the name of asking a trustee and going to trustee's office. I somehow I think you missed it. So an assessment officer is the best person to talk about money. It is difficult to educate 150 doctors in my hospital, but it is easier to have one educated assessment officer.
True, sir. Sorry, I missed that part of it. I joined a little bit late. Now I realized that.
Yeah, I covered that.
Thank you so much. Thank you.
So they are now called financial counselors. So
yeah.
GDS sir, another question for you. I got a response from one of my old, professors when I was a student on the WhatsApp today that monetization is not of interest to me, so that's why I'm not joining this session. So I want you to highlight about how this marketing and branding is not always about money. And even if you're running, let us assume, just for sake of argument, you're running a free hospital or a charitable hospital or a teaching hospital or a research institute, even then there is a role for both, direct, indirect marketing roles. Can you please explain? Because everybody assumes it's always about money.
No. See, we might say, I am not interested in money. I may not be, first point is, I may not be interested in my money, but is my spouse and my children and my all other things are not interested in money? Number one. Number two, suppose we are running not for profit institution. You still need money to increasing salaries every year. All not for profit organization also require capital investment every year. Some instruments are going to be outdated. Some newer models are going to come. The staff is going to ask for a salary rise. Where from that money will come? So money, and the money, one may not be running after money. As I said, people in academic institution, I showed a slide full of crowd, the hall full of people. My academic friends are not after money. A professor of All India or GP Pant carries home a fixed salary. He wants to publish more. He wants to do latest technology. He goes abroad for 6 months. Whatever he has picked up, he wants to master at home. So he also wants more patients. Having, who doesn't want to attract more complex, more, influential and affluent class? The gentleman who did TURP on Manmohan Singh got Padam Shri on just a TURP, right? There are thousands of TURP done every day in the country. So one can't say one doesn't want. I am not interested in Prime Minister of India. He didn't get any money. He got the glamour. And let me tell you, all of us are private practitioners. I will tell you two extremes. One, most of us are teachers for 3 years till our SRship. Then we are private practitioners till end. Second category is that we are teachers till 65 and then we are private practitioners. Then there are third A, when we are teachers till 50. Now everybody knows us in National Capital, Haryana, Punjab, that he is the best transplant guy. His kidney results, transplant are very good. Now I joined Medicity. Now I have been a teacher. I worked hard. I produced results. Now that earning has been consolidated in last 10 years of his work, they amassed so much money only because they did not bother for money in the initial period, but they bother for quality, for doing complex cases. And finally, there is a strange class of surgeons which have come up now, that the person was a teacher from day one till 60 or 65. Now he left a government hospital. Now he is hired by a private college with 5 times the salary or 4 times the salary, 10 lakh rupees, from 2,50,000 to 10 lakh rupees, because the owner of the private college tells the families, the spoiled kids of rich doctors, that your son will be trained by Dr. So and so, that professor who headed All India or SGPGI or PGI Chandigarh. I will not pinpoint one or two. I'm giving a variety. So your son, though a duffer, will be trained by head of PGI Chandigarh. And we will make him a good doctor. We only want 3.5 crore rupees. Right? So everybody needs. Somewhere it is being encashed.
Can I just say I so agree with Dr. Girja what he just said. I think what you said about we should be aware of the costs and all that, because I think a large part of my life I've been sort of acted holier than thou. I'm not going to be interested in all this. I think it should be mandatory teaching in the curriculum, not just the we should be teaching all this. What I've realized is, in our, at least from the government medical college side, there's always been you are going to be, it's a sin to do anything. Like in your CMC Vellore, Ludhiana, the salaries were so low that you had to only be taught those kind of values and hope that you imbibe them. I think it's important to show, and then we throw the same kids into the, open market and say, okay, now you fend for yourself. It's dirty to do any practice. I think we need to teach them formally. All law schools, management schools have practice management. We don't, we are still teaching them exotic, esoteric, case capsules. What is Lutembacher syndrome? Every, MCQ question is ridiculous. So I think what you're saying is absolutely true. And you've given me the idea that, for the next HBB course we do, I'm going to ensure that, in addition to other, hobbies, we're going to have sessions on finance management, practice management, and legal, looking at the legal side, what Marvelous Medicine is doing for the society. I think we need to do it for the kids formally rather than only through informal sessions. Thank you, Dr. Gija.
Thank you.
Doctor, I would like to add something here, very interesting. I was addressing an all India conference. So I was always given a topic like sales and marketing. One of the leading doctor who is running a big institution, he said, he told that whatever Professor Ashok says, don't take it very seriously. I am running a hospital without any marketing. Marketing is not required. If you have skills, patients will come automatically. Then during the lunchtime, he said that I opened one block for international patients. Professor, please come and help me how to get the business. So these are all fundas we can talk today. Healthcare is a business. At the end of the day, we need to do the business in a profitable way, and we need to find a way how to do it. As it is rightly pointed out, if you are a professor over a period of time, you have to make money or you have to be a brand. Now today everything is on branding yourself. So later on it will be helpful. It's become a very high competition. Patients are very, very sensitive. They know everything. All become Google doctors today. So the careful marketing, the sales and marketing are the two eyes of any organization. And I'm very happy to inform you that there is one segment, 2020, we started ophthalmologists. They started practice development conference. In July, they are going to have it in All India Institute of Medical Science. If you attend that conference, it's amazing. Nothing is talked about the science. It's all only the practice management skills it's being taught. Anyway, thank you very much.
I must share that under the banner of Learning General Surgery, we ran a course for young surgeons, 3 months stay with me on art of communication for surgeons and public management. And we had 4 people in 22, 23 and 21, 22. 4 people completed 3 months each in rotation, and they are all very benefited. Then we might start it again.
Thank you, sir. Mr. Rajarajan, would you like to add something now?
Yes, madam. So there was a question about what kind of doctors, marketable doctor, what are the corporates looking out? So, see, there is no one kind. It actually depends upon the kind of person the organization is looking at, the organizational fit. Some of the organizations, even the corporates, have gone into institutionalized practice, wherein every patient is everybody's patient. So what has happened is we are only looking at from the organizational fit point of view, how the doctor would fit into the organization. One. Second thing is, do the doctor have their own practice, or should the practice be further augmented? So there is this whole concept called practice acquisition in corporates. So wherein we actually, like any hospital, which we start out, or whenever we join any hospital, one of the first things that we do is list out the set of doctors or the skill sets which are missing inside the team of our doctors, identify doctors in the market, list 1, 2, 3 in order based on some of the metrics that we know with respect to their skills, with respect to their outcomes, with respect to their patient loads. And based on all those, only the selection is being made. And again, many a times for a particular position, when we have met with many of the doctors, it is not the first doctor who we have selected. It's not the second doctor. We might even meet 5th or 6th doctor. Many of the times, it is the doctor who rejects the hospital as well. So it is to be noted that it's like a system wherein how the organization is looking at this kind of fitment. Even the doctor see how they will fit into the organization with their principles, their values, how the organization would be able to further help them in their ideas and innovations that they want to bring in, and the kind of community service that they want to do. So it's always a mix. There is no one formula based on which corporate hospital looks at a doctor, and there is nothing called as a marketable doctor, or we so brandish. We call doctors who are market friendly. Like, say, my marketing friends, when they call a particular doctor and say, sir, next week we go to CME in this place. There are some doctors, oh, next week, okay, I'll clear up my schedule. I will come over there. So they are called as market friendly doctors. Say, outreach clinic has to be done. But there are certain set of doctors who would not like to go on these kind of ORC clinics or CMEs, and they like to have that practice intrinsic inside the hospital, get the case referrals inside and do it. So it all depends. So there is marketing friendly doctors, but in corporates we don't brandish somebody as marketable doctors. So we go by a fitment criteria, and there is a lot many to it than what is being seen. It's like the tip of the iceberg phenomenon. Thank you.
Yeah, thank you, sir. But I would have one more question. When corporates do actually look at doctors, there are two things. One, I'm not sure how much a non-medical person can actually evaluate the doctor's technical skill other than what it has been, what he or she comes to know about through other channels or hearsay. Apart from that, you said there are certain criteria that you look into it, that these criteria are important, that this particular doctor would fit into my organization. So can you just give a few examples for our understanding?
I would like to draw your attention to a committee called, in many of the corporate houses, we have a very active and one of the most powerful committees called the Credentialing and Privileging Committee. So any doctor who we hire, we run through the Credentialing and Privileging Committee. And as you rightly said, non-medicals are in no way the right people to judge any doctor based on the clinical skill without the inputs and recommendations from the credentialing and privileging committee. So in many of the corporate hospitals today, in a world with a lot of accreditation badges that we like to have, as many in an organization, what we do is we have this committee as one of the cornerstone committees, and this is the committee which gives us the inputs. In fact, when I do mention that we prepare a list of doctors, we rank them, and all the stuff, it's as I did mention, it's about the practice volume that they have. It is about the case success they have got. It is about the kind of organizational influence that they've had in the previous this thing. And as Dr. GD has rightly pointed out, the good ones picked up early. So it's always practice acquisition is one of the toughest and one of the most interesting and adventurous thing to do from the management point of view. I could quote a lot of examples, but just not to name any brands or brands of organization and brands of doctor. I'm not getting into that details, but definitely we could get on a call and discuss further, Dr.
Thank you, thank you.
So actually, it's pretty strange or whatever that most of the things that Professor Girijadhar Sharma asked us to do are actually what we should be doing anyway. Whether we are trying to market ourselves as a doctor or as a service provider or as a business person, whichever way you look at it, almost 8 of the 9 things that GDS sir said are actually the given. So so if you do that 80% that you just if 80% of that is already your practice, that is you're being on time, you're being polite and courteous, you're being sincere, you're actually being available, and when things go wrong you take ownership, and also you take help from friends and experts. So these are it should be actually a basic thing that is taught to anybody who's finishing their MBBS. But beyond that, a few other tips are there. So actually, it should not be very hard at all for one to, for want of a better word, market or position themselves. Radha, you have your hand up. Go ahead.
Thank you, Vidya. So in fact, I had a little chat with Vidya yesterday because I did not understand what direct marketing meant when I saw this thing. And luckily I got home early. And so I was able to get on this. We have a lot, and I completely concur with Vidya. After having listened to Dr. Sharma's talk, it was more about how to be humane, how to bring back the humanities into medicine, how to treat all your patients. So I was like, okay, this is what we should all be doing. The fact that we have to talk about this and present this as marketing is the sad state of affairs. And I even when I was doing medical school and all that, I remember in Madras Medical College, we were more into, okay, what murmur is this? What is this? And and then my very first rotation in medicine, internal medicine, we walk into this ward, as we call it, the floor, and one of my medical student colleagues started presenting this patient, and he started saying, "This is a case of," and the resident, the fellow, or whoever who was, doing the rounds for us, grand rounds for us, stopped him right there. He said, "Hey, this is a human being. This is not a case. So you always, I'm talking to you about this in 1983 in Madras Medical College. So it is stuck in my head. That resident or fellow, whoever was heading the grand rounds, told us that the attending was not even there. The consultant was not there. It was a resident we were medical students. And he said, you always start a case presentation as, this is a gentleman or a lady, of course, in those days, and then this is a so and so with this person has a name, this person has a gender, this person has an age. So you always start with, this is a 43-year-old gentleman or a lady, name so and so, with the presentation off. You'd never start anything with, this is a case. So that kind of got stuck in my head. And then whatever Dr. Sharma said resonated so closely to my heart, because it was so much about how to bring humanities back into medicine. And I've taught this Healer's Art course and talked to medical students about this. I've mentioned this in another Marvelous Medicine course as well. So it was very, very nice the way you put it, whether in private practice or in academic practice. Even in our hospital, we have patient advocacy. So patients can always talk to this person to be a liaison if there's any issue. And also, very true, practice management was not something that was taught to us in medical school or in residency or fellowship or anywhere, even in this country. Now they're starting to, all the societies are starting to do practice management courses. And some of the consultants, so to speak, have started talking to residents in their final year about how to negotiate contracts and what to look at, what lines to look at, what should we be thinking about and stuff like that. So, money is important. Money is not everything, but money is important, which is what you just have to find a balance. Thank you, Vidya.
GDS, sir, would you like to respond?
No, I think I agree with we were part of our residency system with American missionaries, had all these things embedded during our training. That was the great point.
Thank you, sir. Over to you, Radhakrishna. We are almost nearing the end of the session. If anyone has any comments or questions, please put them in the chat box or turn your camera on or raise your hand. Over to you, Radhakrishna.
Yeah, it's always nice to listen to Dr. GDS. I've been listening to him in person or online for so many years now. It's really, really wonderful. I have a comment or a question both to Dr. GDS as well as Rajarajan and Ashok. Now, as has been mentioned by Dr. Radha quite recently, now most of us studied in public sector colleges and hospitals, whether it is undergraduation, post-graduation, whatever. Now, the points you've been mentioning, Dr. GD, is that how you treat your nurses, how you give them gifts, how do you appreciate your residents, and how do you talk to relatives, and how to sit with them in privacy and talk to patients' relatives who are in trouble. These things are not there at all in the colleges where we have studied. Anyway, this is never a part of the system. For the matter, the patient is dying, the chief does not know, he'll only know the following morning. I mean, that was the situation earlier. Even if you take private medical colleges for the matter at this juncture, many of them don't have patients. Where do we learn all these from? After joining the corporate sector by trial and error, or is there a course in between? I really do not know. Professor GDS to respond.
I think I agree with you fully that there are no places where people can go and learn. But this part we can initiate at least some 15, 20 out of this gathering are all capable. Say 20 people here I find are capable to help people where they can come, stay for a while and say spend 3 months. I mean, we tried, and the first candidate I took was Vinayak Ranjan, and subsequently a girl from Hyderabad, then another guy from Bangalore. I mean, they all went wiser. Besides, they learned some trauma surgery also. But this is a very important aspect. This is strongly lacking in all the educational institutions across the board. This is not taught anywhere. And the success of the guy depends 50% on this. You know, people who have undergone a good resection anastomosis, healed in 5-7 days, going home in time, still at time, suddenly when somebody wanted to talk to the doctor. Another point which I want to raise is, if I am, this every word has a meaning, if I am unhappy from my current employer, do not reflect in your everyday work, because that will upset my ultimate employer. My ultimate employer is my patient. It is this common man who gives money for my expensive driver, for my cars. They give enough money that we are not bothered whether the petrol is 100 rupees or 150 rupees. So we need to look after these people with that kind of attitude.
Yeah,
And
yes, sir.
And I think LGS is, if we want this to be done through the central government and through the NMC, those things will probably not happen for 10 years. What we can do today is that some 20 people on LGS can volunteer, say 15 days fellowship with me, 50 days with you, 15 days with somebody else. The guy spends 2 months. This can be the outcome, positive outcome for this meeting, that in 2 months he goes to 4 different people and all throughout. My hospital never wanted this, so I financed it myself. And say 2 years ago, we were spending around 25,000 rupees per month on a candidate. I said, I will give you free place to live and food to eat. That's all which I can give you, and no charges for the education. And they all went very happy. Then I had to change the hospital for some reasons. So at a new place, we have not started, but we can start again. And if 3, 4, 5 people club together, so the gentleman spends 2 weeks everywhere, and it will be a nice contribution to society. And it, for all well-settled people, it is a peanuts. We can sponsor ourselves.
Rajarajan and Dr. Ashok, see the words footfalls and profit and business and making money. These are very new terms to us. And I really hate the word footfall. You know, Ashok has got his habit of using it very frequently in his lectures. I've attended some. He's a great lecturer, I should say. Now, I wonder, about 50, 40 years ago, there was no marketing actually. For that matter, none of the public sector hospitals have any marketing section now. Where did this marketing crop up from? And, you know, for then, the marketing has become so competitive, and it's dirty in competition now that you have a huge role in spoiling doctors, and I should say to some extent the profession. Then the doctors themselves, I'm really worried about that. Okay, now Ashok says if there's no marketing, patients don't come. Where will patients go? They have to, they're sick, they have to come to the hospital. Marketing, no marketing. And I just wondering how will it be if you control, alter, delete marketing, hospital marketing altogether from the face of the earth? Rajarajan.
Uh, very good point, sir. But yeah, we need to coexist. So yeah, starting with the peace treaty here. So per se, see today you did mention about footfalls, but then there are very bigger concepts now called funnel management. Right from the time a lead is generated to the time the patient comes in as a footfall, the nudges that you have to do between that. It's not after the patient lands in. Lead management from there to the time they come in. The nudges, pushes, all those things that has to be done, and the journey management during the course of hospital, and post the journey management, the engagement that has to be done. And honestly speaking, all this with good clinicians in their own practices, these are some of the hygiene factors. The good doctor would always write when is the next follow up, and the patient, the secretary over there follows up for the thing. So today we call it in different names, but it's all old wine in a new bottle per se. If we have to control all Reddit and get the marketing out, I think marketing has always coexisted. It's just that it was in a very subtle way. It was not highlighted so much, but now we don't have a time machine to go back and set things right. It could be probably the time when hospitals can be a private limited company for profit. You can't go back to that one point of time and change it at this point of time. Whereas even today, educational institutions in the country cannot be a private limited companies. They need to be, even more so now, hospitals could be public limited as well. So we have had a lot many corporate hospitals, many of the corporate acquisitions. Today, a hospital bed on an average in the last 1 year, the acquisition standards say that, statistics say that each bed of a hospital group is acquired between 1.2 1.4 crores, which is the minimum in the last 1 year, to 2 crores per bed. Okay, so we are living amidst this whole thing of monetization, and as Dr. GDS had put it nicely, monetization happens even in a missionary hospital, even in a society run hospital. Every hospital there is a monetization happening. That monetization which is happening happens very subtly, which happens say with an assessment officer or a medical social worker or admission counselor. So at various sectors today we do say that doctors are not to give treatment estimates to the patient. We try to distance the financial thing, because today patients are perceiving that the doctors talking about financial estimates makes them see doctors as in a different light as such. So since we, still some of us are there who treats our doctors, the profession, as a very noble profession, and look at ways of doing this ethically as well. So we have been advocating all this, and slowly we have been having some success. But one important thing is definitely the need of the hour is the finishing school. Uh, Teaching the right things to these people on, the young students who are coming out, on how these things have to be approached. You were talking about the MBBS curriculum, post curriculum. Even the so-called MBAs which have come in the last 15, 20 years, even there we lack these kind of teaching. Today, many of the institutions have, by law, have started taking people professor of practice. I was approached by 2, 3 MBA healthcare institutions to enroll me as a professor of practice, wherein it is not only the academic set of people who will teach them, but somebody from the industry goes, shares our real life stories, share the application oriented aspects. Earlier Dr. Punitdar also had mentioned the kind of MCQs, the kind of cases that which we put together, and this thing, all these have to change. But Rome was not built in a day. And going back, to the famous quote by Margaret Mead, never, it's always a committed group of people who could make the change. And Dr. GDS had well brought that out, saying that, the change has to happen, and the change can happen from here in this group. So we could further take this offline, build a course curriculum, standardize it. The one of the important thing is about the consistency of delivery, wherein when any of us, if the student is going to work with Dr. GDS or Dr. You or any other doctors in this forum, they need to get the standardization of what is being delivered to them, the consistency in which what is being delivered to them. So we can't, we can't take marketing out of it. It's like it's inseparable, but you can do it the right way. You can do it ethically, and Dr. GDS had brought out many of the things, the various hygiene factors which has to be mentioned. And marketing is not so complicated. We have complicated it. It's very simple. These hygiene factors, if it is followed, it's very easy. But these have to be taught to the people, because the younger crowd, even I feel I'm aged now. I'm in my 40 plus now. So the younger crowd, the bravados, as well put out by Dr. Punitdar, their concept, their thought process is completely different. We all need to, refine the thought process in certain ways, which would not only benefit them but the society at large. Thank you.
Yeah, a question to Dr. Ashok, if it's still there. I mean, you move from institution to institution marketing doctors. You are given a basket of fish. Some fish are very good, some are not so good. But you keep selling all of them. How can you sell not so good fish with the same thing, the zeal with you sell good fish?
Doctor, very good, nice question. As a professor of IIM, and I also a faculty in IIT, why I am continuing as a CEO is that I am testing all the postulations, what is going to work and what will not work. And second thing is that I am seeing that the industry is getting evolved over a period of time. There was no need, and I am now in the 4th decade I am serving in this industry, where there was no need for anything like sales and marketing. There was no HR, nothing was there in the hospital. Word of mouth, people are coming to the doctors, they were getting treated. Doctors were treated like gods. Like when you go there, your disease is getting, your problem gets resolved, you are alleviating from the pain and suffering, you be there. Things have changed over a period of time. As you rightly said, once the corporate started coming in, the management aspect has come into that. So what's happening today is that in a tough competition, you see one more thing, sir, how things have happened is that a doctor study for 5 to 7 years he studied. Then after the 3 years, 13 years he has to do hard work. Then after that, to see 1 lakh or 1.5 lakh, or to go and hold the harmony scalpel, how much time it takes. See the struggle and see the money what they've spent. See the other end, an engineer coming and just getting passed in IIM, going to abroad, started getting 3 lakhs, 4 lakhs and all. And see the life of MBBS doctors, who are really struggling like DMOs and other thing and all. Having studied so much, having acquired so much knowledge, the quality of life of the doctors, it's not an improved. One good thing what has happened after the corporates have come is that the managerial aspects have come. And doctors rightly pointed out that doctors are very poor in financing, in managing the finance. You can get the stories that how much money they lost or they are losing every time. It's all because that the industry is not evolved. And why the hospitals are not so much organized like factories, like things are not going. Even today, a doctor has to, when you're going for a surgery, 10 times you have to be very clear. Has it been done? Has it been done? Has it been followed? And the new thing has come is that the Consumer Protection Act. We have to protect ourselves there. There are so many things which has got changed completely, and everybody talks about the EBITDA. So the newer concept is that you open newer branches, you spread your tentacles, then make it as an IPO and getting into international arena. See, the concept of healthcare is changed from the simple treatment to it is into a healthcare business and blue chip companies. We talk it as a blue chip companies. You make brands and then you become a brand, and then how big you become, how soon you can become IPO like that. So what happened in this thing scenario is that the one thing is that the component of doctor's salary has also gone up over a period of time. In corporate or in any hospital, the biggest thing is that if you are having 10 doctors and if you're running it, and the problem is that it is very difficult to manage cost. Every time when we talk about doctors and others, the biggest problem comes is that the percentage we talk, what is the percentage of employee cost, doctor cost, fuel and power, rent, and all such things. So today, getting a 10% EBITDA has become a very, very difficult because you have to manage everything. And the greatest advantage is that once the corporate come, the care is improved, and the type of disease what we treat, the transplants and other things has improved. Really, it is more than international standards, I can say, in some of the things. So in the future days to come, it is getting evolved. Sales and marketing is going to be the order of the day. And all that, as sir has rightly pointed out, the negotiation skills and selling ourselves and how to survive in the tough competition is going to be the main thing. So it is very important for the doctors to learn the managerial aspects and learn from other industries, and then the survive in this highly competitive world and protect ourselves. Thank you very much.
Rajiv, Patni, you have your hand up. Do you want to say something? Please unmute yourself.
Thank you. सबसे पहले तो प्रणाम Dr. Sharma. Wonderful, truly masterclass, truly a masterclass. It's such a wonderful session happening here that even though my wife is calling me for dinner, I'm unable to pull myself away from this session. What we have seen is something called direct marketing that Dr. Sharma spoke about, and then the sales marketing that Rajarajan and Dr. Ashok were talking about. That's the corporate side of things, and luckily in the discussion, all of us got the benefit of an exposure to that as well. Just one incident I wanted to share with you. Since I'm here, maybe it was covered. As a very young doctor, about 35 years back, I had referred a case to Dr. Patni in Agra, and I knew this patient would not pay. Dr. Patni was a very senior doctor at the time, and he saw the patient, gave the full treatment, and everything was taken care of. I called him to thank him. And I said, sir, I am very sorry I sent you a non-paying patient and all. I said, sorry, but the patient came back to me and said, you treated them very well. And he says, Doctor Sahab, meri teaching to ye rahi hai. My teaching has been that even if my peon refers a patient, I will give the patient the full respect. You are my colleague. That was huge. That was huge for me. That was very humbling and a great learning for me. We respect each other. We show respect not only to the colleagues. We will share and convey the same respect to every member of the staff who may bring some patient or come with some need. whether it's for person or for his personal family or friend or just a referral. And that in turn generates many more leads. I just thought I'll put this on the table. Maybe, sir, you have already discussed this thing. But thank you, one wonderful session. Yeah.
Thank you.
Your closing comments, GDS sir.
I think all these things which we have discussed are teachable arts, which the last generation learned from their teachers the way they practiced. The current generation is missing. It is part of our responsibility to impart this to the next generation. How many of us will contribute will really matter in the number of people we can train. That's all what I have to say. Thank you, everybody, for patiently spending time late in the evening. Thank you very much, Dr. Vidya, for the opportunity given. And I would like to be again sometime on a different non-surgical topic. Thank you.
Thank you so much, sir. I know Thursday is a busy day for you, and you also have family visiting. So thank you so much for sparing your time, and especially when you have just recovered from your problem, you were still willing to risk it by spending more than 1.5 hours with us. And thank you, Mr. Rajarajan and Professor Ashok Tyagarajan, for being here. So we'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Okay.